Good morning. Today is AML World Awareness Day, and we welcome you to our webinar, Living with AML, a Clinical and Research Perspective. My name is Linda Thompson. Working alongside me today are my Leukaemia Foundation colleagues, Marianne Scaparis and Linda Saunders. Together, we will be facilitating today's webinar. Before we commence formal proceedings, the Leukaemia Foundation acknowledges this webinar is being delivered from the lands of the Whadjuk Noongar people of Perth, the Turrbal people of Brisbane, and the Wathaurong people of Geelong. We also acknowledge the traditional owners of the various lands from where you are viewing today. We recognise that their continuing connection to the land, sea, and the community. We pay our respects to the elders, past, present, and emerging. A diagnosis of AML is life-changing. Adjusting to living with AML can be both challenging and stressful, not just for the person with the diagnosis, but for those around them. Not only are there physical impacts of the disease, but it also extends beyond to emotional health and well-being. So in this webinar, we're covering some of the emotional and lifestyle effects and some of what is happening around the advancement of AML research. So our hope is for you to be more informed, and then the better you are equipped, you'll be able to live as well as possible with AML and enable you to make informed decisions. So without further ado, I'd like to introduce our first speaker, Tim Eggleston. Tim is going to share his personal experience of living with AML. Take it away, Tim.
Oh, thank you, Linda, and thanks for the opportunity to participate today. So I was diagnosed with acute myeloid leukemia in June 2018, so coming up for 4 years ago. I live in a regional centre and I'm 3.5 hours away from the nearest capital city. So it was a bit of an issue getting referred to a haematology service in that capital city, but I was eventually had 2 rounds of chemotherapy during 2018. I did have problems with my blood counts recovery after the second lot of chemo, so they basically stopped the chemo there, but I was in remission. But the following year I relapsed and my bone marrow biopsy showed that the leukemia had come back and I was slated for a bone marrow transplant, which I had in July 2019, so about 2.5 years ago. It was an unrelated donor, so an overseas donor, which was found through the International Bone Marrow Donor Registry. And that's been, as far as I know, to this stage, very successful. I went back to work in January 2020, part-time for a while, and then now I'm back full-time, and as much as is possible, I'm sort of back to normal. Probably the main ongoing issue is a bit of mild GVHD of the skin on my back, which of course is not unusual for bone marrow transplant patients. So in terms of the challenges and the life issues, if you like, obviously the stress and anxiety of being diagnosed with a life-threatening illness has been an issue for me. Curiously enough, it's probably been as much long-term as short-term. At the time I was diagnosed, I had a pretty fair idea that it was going to be a blood cancer diagnosis, and I was most anxious about being diagnosed with multiple myeloma. And in some ways, the leukemia seemed a milder option, but I must say I have had long-term sort of stress manifestations of the whole issue of anxiety and stress around the whole process. So, and that's still an issue even now, even coming up for 4 years from diagnosis. Being in a regional area was a challenge. As I mentioned, there was a bit of a process of getting referred to a haematology service in the city. There wasn't a haematologist in my regional centre. The hospital wanted to refer me to the local oncology service, which didn't seem very satisfactory to me at the time, and I think in hindsight seems even less satisfactory. There wasn't a great sense of urgency. I managed to get a referral to a haematology service in the city and was rung within 2 hours by a haematologist and the next week I was down there for a bone marrow biopsy. So that was a bit of an issue. And of course, being in a regional centre has other issues as well, which I'll talk about in a minute. One of those things was the challenge of being relocated to the city for an extended period of time. So I had two stints in the city, one while I was having chemotherapy and one while I was having the bone marrow transplant, stem cell transplant, and then recovering from the stem cell transplant. Obviously, there are stresses and financial pressures involved in that. I'm a person who likes the outdoors and likes the natural world. I love my garden. So being relocated to the heart of the city for 4 months with the noise and the lack of privacy and the busyness, I actually found that really challenging. And I must say it was great to get home when I finally did. Of course, I also missed a lot of work. So I had a period of 4 months off work, followed by a period of returning to leave part-time in a sort of graded return to work. And then later, when I had the bone marrow transplant, I had another 6 months off work, followed by another period of part-time returning to work. And I did have a lot of sick leave up my sleeve, which was great, but I eventually ran out of sick leave. So there were financial pressures involved with that. It so happened that my partner and I had taken on a fairly significant financial commitment about 6 months before diagnosis. So that was a challenge. But I must also say that those financial challenges were very much helped by the financial support that I got, which I'll talk about in a minute as well. But I think the other thing is I didn't have any trouble returning to work physically, because as you might be able to tell, I work in an office, I work at a desk job. So I didn't have any physical challenges, but the mental challenges of returning to work after a significant break were quite powerful. My organisation happened to have gone through quite a lot of change in that time. So I had to learn new structures and new systems and relearn systems and skills. I lost a lot of confidence. I felt like people had all gone forward in the organisation while I had sort of stood still. And it's really taken me at least a couple of years to regain some of that confidence and those skills and feeling part of it. So in terms of what's actually helped in terms of support, well, first of all, above and beyond everything else, the absolute expertise and care of the medical teams has just been amazing. So everyone from the haematologists, the nursing care, the nursing teams, the allied health teams, social work support, I think it's just been amazing. And that I think is the main thing I suppose I'd like to emphasize in terms of support. I've also had support from my family and my partner, and that's absolutely crucial as well. I do remember my haematologist saying to me at one stage after my transplant, he said the most important, the key thing in terms of long-term recovery is the support of a partner. And he always really worries about the people who don't have that support. And I've been lucky to have support of both my partner and my family. And I did happen to have family in the city where I was being treated. So I felt like I had close by support as well. And of course, that support is both practical and emotional. I've got to also mention my donor. It's a pretty amazing thing when someone who you have never met and will never met, or probably will never meet, and who's from overseas, and in a completely altruistic sort of offer, goes to the trouble of registering with the registry and then going ahead with donating stem cells. And of course, not only that, but the actual mechanics of the bone marrow registry, the donor registry, it obviously works, and it's an amazing example of international cooperation to the benefit of people like me. And I'm pretty sure without my donor, I probably wouldn't be alive now. So that's pretty significant. I got a lot of support from the Leukemia Foundation. I got financial support in the way of accommodation. I got financial support from IPTAS, which is the New South Wales Isolated Patients Transport and Accommodation Assistance Scheme. And I was also lucky to get financial support from my superannuation fund in the way of a temporary incapacity benefit, which wasn't the same as my full income, but certainly helped. And there was also a lot of other support from the Leukemia Foundation. So I got transport support for getting to and from appointments. I was offered the support of a local support person in my regional area, and that was great. Never exactly formal counselling, but certainly support and informal counselling. And that's actually been ongoing even right up to now. I've also had a lot of support in the way of attending the webinars that are run, the support group webinars. Unfortunately, I've never been able to attend an in-person support group because, of course, COVID put an end to those. But yeah, I feel people who have had leukemia and a bone marrow transplant, they're my tribe, and being able to meet with them online and just communicate and share experiences and stories has been really good. I also did some practical things for myself, which I think were important. So right from the time of diagnosis, I've kept a fairly extensive diary, and that was a coping mechanism for me. But it's actually also a really handy thing to have, because you've got a record of all the treatment and all the appointments and all the blood results and all of those sorts of things. And I think that can actually help in your dealings with the medical team, because you've got your own history of what's happened, as well as, of course, how you feel about it and how you think about all of that sort of thing. I learned about mindfulness. I did some yoga and some relaxation. I made sure to keep up my exercise as much as was possible. And I also took the view that that I should be absolutely open about my situation. I never tried to hide it from people, and I think that for me was a coping mechanism as well. And finally, just to wrap up, I think the thing that has probably helped the most was that it was a piece of advice that I got from my initial treating haematologist right at the very start. And I think it was even right at the first appointment. And he said that it's quite important, especially in these sorts of situations with blood cancer, is to never get too far ahead of yourself, to take each situation and each change as it comes, and make decisions and worry about that without worrying too far into the future. I've tried to follow that all the way through. I think it stood me in good stead, and I reckon it's helped significantly to cope with that mental and psychological challenge of being diagnosed with and being treated for blood cancer.
Thank you very much, Tim. We appreciate that. It's really great, I think, when people are able to share their story like that, and when you can talk about, you know, how you managed the challenges that you came up against. I think it helps people to not feel so alone in what's happening to them, that these are things like, you know, the financial and the psychological, like the emotional side of things. I think it's very helpful. So appreciate very much for you to share that with us. Next, I'd like to introduce our next speaker, Professor Andrew Way. Professor Andrew Way is a clinical haematologist at the Peter McMullen Cancer Centre and the Royal Melbourne Hospital in Melbourne. He also runs a laboratory in the Division of Blood Cell and Blood Cancer, Walter and Eliza Hall Institute of Medical Research. Dr. Way has been a leading contributor to the clinical development and approval of venetoclax for older patients with AML, as well as oral azacitidine as maintenance therapy for patients in remission, not eligible for stem cell transplant. Welcome, Dr. Andrew Way.
So thanks for asking me to speak to you, and thank you, Tim, for sharing that information, which I think is something which I'm sure will resonate with patients and also relatives who are listening today. Today we were, as you may have heard, supposed to have two clinical speakers, And unfortunately, my colleague Paula Marlton, who was supposed to give the introduction to leukemia in general, is not here. And my brief was to talk about more the research side of things. But what I will do is just start off by perhaps reflecting on some of the things which Tim has said. And first of all, from a clinical point of view, obviously it's incredibly difficult to try and convey the full spectrum of what a patient is going to go through once diagnosed with leukemia. And our observations have generally been that most people feel that there's a information overload, especially in the first couple of days. And often there is a sense that patients have gone from fairly normal existence to almost overnight being thrown into a scenario where their whole life has been put upside down. The other observation I'd make is that it's very hard sometimes for patients to comprehend the disease because it's invisible. It's not like something you can see. Because it's in the blood, it's very difficult to explain that something which a patient can't actually see is actually life-threatening, life-changing, and just the concept of one having to be in hospital for a month and to have treatment for many months, and then possibly followed by a transplant, as Tim has explained, very, very challenging to come to terms within the first sometimes few days or even weeks. So what we try to do is to give the patient time. And as Tim mentioned, many physicians try to, in that sense, partition the amount of information we give to what's necessary today for the next few days, and then for the next few weeks, and then more longer term information as time goes on, just to make it less overwhelming. But even then, it's very difficult. With respect to trying to comprehend leukemia in the broader sense, one of my observations is that that the treatment is very difficult to explain, mainly because there's so many aspects to it. There's the chemotherapy bit, these new terms called induction and remission and consolidation and transplant. And blasts and all these terms, which I'm sure many people have heard of before. It's like almost trying to teach someone a new language from no knowledge whatsoever, and that is incredibly challenging. So I will start off my talk now after those brief few words, but suffice it to say that in Australia, about 1,200 people are diagnosed with this condition each year. The average age is about 68 years, so that means 50% of the patients diagnosed are in their 70s and beyond, which obviously presents many of its own challenges. So I'll just get my slides up. And so my talk will be not too information heavy, because I know sometimes that can be, again, overwhelming. And what I'll do is I'll present these slides, and then obviously happy to take questions afterwards. But I've been working in AML now for probably 20 years, and it's the major area of my clinical and my research interest. And currently, as mentioned, I work at the Peter Mac and also the Walter Weiser Hall in terms of research. So why do we need research into blood cancers? The reason is that, as you can see, this DALY stands for essentially life years lost from various cancers in Australia. And you can see here collectively, blood cancers, the number of days and adjusted life years lost collectively, as you can see here, is higher than many of the solid cancers, which are much more frequent than blood cancer. And so clearly a lot of progress is required to be made, and hence progress requires research. In trying to explain what leukemia is, most people will be familiar with the fact that it's a bone marrow problem. And normally our bone marrow makes all these different sorts of blood cells, which are required for delivering oxygen to our tissues, clotting with respect to the platelets, and fighting infections with these cells called neutrophils. Again, all these terms I'm sure everyone would have heard of before. What happens in leukemia is that one of these, what we call stem cells, has been transformed. And what we mean by transformed is that it becomes abnormal in terms of its growth and many other factors which are not normal. And so essentially, leukemia is not some foreign invader into our bodies, but it is actually one of our normal cells which has been transformed into something very abnormal. And it's abnormal because, one, it doesn't make the normal cells, which I've shown you before, which is why people's blood counts go down. And secondly, you can see it grows out of control such that these cells eventually take over the bone marrow and then spill into the blood. Spilling into the blood usually is a more later manifestation. And for that reason, the only way we can quantify how many leukemic cells there are is to do these recurrent bone marrow biopsies, which unfortunately, there's no easy way around that. The next thing I want to try and explain is, why do people get leukemia? Because that's a key question which everyone has when they come in. Almost every patient asks at some point, is it something to do with diet or exercise? And unfortunately, with acute leukemia, it's generally not associated with those two things. What we know is that many patients with leukemia have what we call mutations. What is a mutation? Well, a mutation is just a change in the DNA code. So you can see here, this is one particular DNA code, and you can see it's just sometimes one letter which changes. And if that letter affects the coding or the instruction manual in a critical gene, then that can be enough to basically transform the cell, like I showed you before, to create this sea of leukemic cells. Now, these mutations can occur in lots of different genes, which affect a whole host of different functions, which are called hallmarks of cancer. And so this is not specific to leukemia, but this is a concept which is common in all forms of cancer. Basically, coding errors, which changes the instruction manual, which then causes the programming of abnormal biological behaviors, which then causes cells to grow out of control. And to try and understand, well, why do these mutations occur? Let me try and explain that by saying that each day, our bodies make 100 billion white cells every day, those cells that I showed you before. And to make each new white cell, each of these 100 billion white cells every single day, the body or that cell has to copy the DNA code from one cell into another cell. And it's a bit like copying the Encyclopedia Britannica, all of the volumes in 20 minutes. And the copying is very good, but it's not perfect. And in 1 in every 3 cells, there will be this type of error in terms of the copying. And most of the time, these copying errors occur in genes which are not important, and hence we never see the manifestations of leukemia in the vast majority of people. However, if you can imagine every 3rd cell having one of these errors and 100 billion cells being made every single day, by the time you get to your 50s, 60s, and 70 years of age, you can understand that numerically the chances of one of these mutations occurring in a gene which is critical for one of these functions can occur, and that is the cause of leukemia. Now, there's lots of different genes which can be affected, and that's why we generally do what we call next generation sequencing, which is to try and sequence many of these critical genes to identify the cause of the leukemia in a particular patient. And this is just here to highlight how complex acute leukemia is acute myeloid leukemia. So far, there's mutations identified in over 200 different genes, and each patient has on average about 13 different mutations. And so because it's so complex, that's why treatment is very difficult, because we can never design a treatment which is truly personalized to one patient, because no two patients are exactly the same. The other concept to get across is that leukemia is not a static disease. And so this is just trying to illustrate that this is the patient at diagnosis. And you can see that during treatment, the type of leukemic cells that are present change over time. And that's because it's never one population of cells. In many cases, even from just what we can see, there's 4 or 5 different populations, as you can see here, 1, 2, 3. And then at the time of relapse, a completely new population emerges, which wasn't even visible with our current technologies at diagnosis. And so this is the concept that leukemia is a moving target. And so when someone has leukemia that comes back, which is obviously an incredibly difficult and unfortunate situation, it's not because we gave the wrong treatment, but we couldn't even see that particular clone, as we call it, at that time. And so therefore, leukemia is an evolving feast with respect to remonitoring to try and understand what cells we're dealing with, and involving many phases of treatment, which include induction, what we call consolidation, sometimes maintenance therapy. Tim talked about transplant, and that's all just to try and provide different types of treatment to try and cater for all the different myriad forms of subleukemias which are present in an individual patient. Now, one area which I'll talk about, which has really, I guess, transformed the way we treat leukemia, particularly in older people, is modifying the cell survival mechanism. So increased survival or inability to be easily eliminated is one of the hallmarks of leukemic cells. And trying to modify that with new drugs has been a goal of research for many decades now. And so what we know is that every single cell in our body, normal and abnormal, has a programmed cell death mechanism. And that's given this term called apoptosis, which is actually apparently in Greek, the name given to the falling of leaves. So when leaves turn yellow and fall in autumn, that's a programmed cell death program being activated in the leaves. And there's a similar program in every cell in our body. And this was first described, in fact, by a Queensland pathologist called John Kerr. And he described this process where when a cell dies, it fragments and forms these very characteristic features, which he called apoptosis. Now, chemotherapy, which most patients with leukemia receive, has been around for a long time. So in fact, Ara-C, which is a name which many people will be familiar with, and daunorubicin or idarubicin, you can see here these two drugs for leukemia were discovered way back in 1950 and 1963. Ara-C actually comes from this sea sponge called Cryptotethia crypta, and was discovered off the coast of Florida way back in 1950. And the extract of that is now used as a chemotherapy drug. And daunorubicin or idarubicin was actually discovered from a soil fungus called Streptomyces. And so again, these are naturally sourced products which have been used as chemotherapy for over 50 years. And in fact, these drugs work by, in fact, inducing programmed cell death in leukemic cells via apoptosis. And so why do we need research? Well, we need research because to successfully treat a disease, we need to understand it. If we understand it, we might be able to control it, especially with new therapy. And if we understand its origins, then maybe in the future, we might be able to prevent it as well. And so these are the sort of 3 major objectives of research. And so One of the goals of research, which commenced over 20 years ago, was to understand how does apoptosis or programmed cell death work, and can we understand it and control it better with new therapies. Now, over 20 years of research, which actually began in Melbourne, actually, by a scientist called David Vo, working with Suzanne Corey and Jerry Adams in the Walter and Eliza Hall Institute, which is where I'm sitting right now. And in fact, David Vo was in the division where I'm currently working in, and he discovered the function of this particular protein called BCL2. What is BCL2? Well, BCL2 is a guardian of the cell, which actually stops the cell from dying and stopping this process called apoptosis. Apoptosis occurs when other proteins bind together, and when this happens, then the cell is essentially executed via this process. Now, you don't want that to happen in normal cells, and that's why we have lots of guardians to try and stop this from happening. However, when the body wishes to eliminate a cell, it increases these other proteins called BH3 proteins, which I'll give the name assassins just to make it easier to understand. So if you have enough assassins in the cell to overcome the guardians, then you will trigger apoptosis or cell death. And so David Vo's research initiated pretty much 2 decades of research to try and understand all of these proteins so we could do something about it therapeutically. And so the end result of all of that research was the discovery of this drug called venetoclax a number of years ago, which was a molecule which could actually fit into this groove on the surface of BCL2, and I've drawn the groove here. And what this drug does is it provides a blocking agent against the cell guardian. And so if you block the cell guardians, then you allow the assassins to do their job more effectively because there are less guardians available. And that's sort of how venetoclax works. Now, as a single agent, venetoclax works very well in a different type of blood cancer called chronic lymphocytic leukemia. However, it was discovered that in AML, that just using venetoclax on its own was insufficient. And that's because you can see there are other guardians which are still operating, which are not blocked by venetoclax. So research gave us the knowledge that if we use a little bit of chemotherapy, much less than what we normally use, that we can increase these assassins and help to block the other guardians. And in combination with venetoclax, we can now more effectively induce cell death in these leukemic cells. And so that was done, venetoclax plus a little bit of chemotherapy. And in the first trials that were done with venetoclax in combination with chemotherapy and AML, and these were in patients, you can see here with an average age of well into their 70s, we were starting to see response rates or remissions in over half the patients, which was far higher than what we had observed previously. So this was very early indication that targeting BCL2 with venetoclax was potentially very exciting. And then this led to what we call phase 3 studies, which is what is often done in clinical research to prove that a new therapy works. And you can see here the venetoclax in combination with a low dose of chemotherapy called azacitidine resulted in a remission rate of 66% compared to less than 30% with our previous therapy. And that the proportion of patients who were able to survive with the addition of venetoclax was substantially increased. And on the basis of these results, this drug was actually approved in Australia for general use just in December last year. But you can see that when the research originally began in 1988 till 2020, that was over 30 years of research from the discovery of BCL2 to the approval of a drug in Australia for that purpose. So it just shows you how long it takes to understand the pathway, develop a drug, do a phase 1 trial, do a phase 3 trial, and ultimately to get it approved by our governments for general use. What we continue to do, however, is to try and understand how to make these therapies work better, because although we have improvements in outcome, the outcomes are still not perfect. So what we do is we take groups of patients who receive these therapies. We divide them into patients that have long remissions but relapse, and also patients that don't go into remission at all with the therapy. And we try to understand what types of mutations are responsible for these three different outcomes. And so this allows us to identify some patients that if they have these two particular mutations, they do really well with therapy. And that's important for us to understand and to obviously inform the patient of that information. Second, we identify other mutations where patients go into remission initially, but then they do relapse. And our job now is to understand how do we improve outcomes more effectively for such patients. Research is also moving into the use of much more sophisticated technologies, right down to what we call the single cell. And so one of the biggest directions at the moment is understanding what's going on in every single cell within a patient's leukemia. And so this requires a lot more technology and research. However, it is giving us unparalleled information, which we hope would be useful in terms of making more accurate treatment decisions in the future. Now, why does an initial remission not necessarily mean a cure? And the reason for that is, if you can imagine this iceberg analogy, where this is the leukemia that we can see under the microscope, which is, as you can see, just a fraction of the actual amount of leukemia within a patient. And so most of the leukemia is not actually visible. And that's why even after an initial cycle of therapy and we tell the patient, things are going well, you're in remission, what we have to deal with is all of this invisible leukemia, which is there, but we can't actually see it. So over the last few years, new technologies have been developed to try and measure leukemia at much lower levels than what we can see with the microscope, which is represented by the red zone here. The reason that's important is because we now have the capacity, after giving initial therapy, to measure much lower levels of leukemia. And you can see here a diagram where this patient's gone into remission, and now we can start measuring very, very low levels of disease before the patient has any symptoms. And the reason we want to do that is because we now have the capacity to measure these increases in the amount of disease at levels below what we can physically see, so that we can give treatment before the patient actually relapses. And I think this will be the biggest research direction which the world will probably follow over the next decade. The reason why this is so important is because venetoclax, which is the treatment which I mentioned before, instead of giving it to someone who's got lots and lots of disease, we now have the capacity to give it when the patient has evidence of the disease rising, but many months before they actually become symptomatic. And the reason that's important is because we have the opportunity now to actually change the course of leukemia whilst the patient is still well. And the benefit of this approach is that we generally don't need to give the patient any blood transfusions. If we treat early enough, there are very few side effects from treatment at this stage of therapy. And because of that, very few medications. And this is overcoming many of the bugbears which patients with leukemia have to face in terms of needing transfusions, having lots of side effects, having to take oodles of medications, and having to be in the hospital for a long period of time. If we can move everything forward by a few months, we have the opportunity to deliver effective therapy at much less cost to the patient, which I think is going to be a really important outcome. And so we've been so impressed by this type of therapy that we've actually developed a whole new trial, which is based upon this concept, which we've called INTERCEPT. And the goal of this trial is to intercept the leukemia using very sophisticated and highly sensitive measures many months before the patient becomes unwell, with the goal of trying to change the course of the disease in the way that I've discussed, and using very targeted therapies. And so this is a trial which is being run and opening in Australia in the next few months, which the Leukemia Foundation has contributed to. And our aim is to provide the best therapies currently available in the world today in a very precise manner, using very sensitive technologies and giving these therapies, hopefully whilst the patient's still well, to prevent them from becoming unwell if the disease is looking very highly likely to relapse. And so I'll stop there. I did promise not to try and give too much information to enable questions to be delivered, but just to show you that this particular trial is a collaboration between basic scientists, hospitals in Melbourne and around the country, even overseas collaborators, and many funding partners, including the Leukemia Foundation, to make this type of research possible. And with that, I'll stop there, and happy to take any questions.
Thank you so much. That's very interesting. And I think, you know, how you explained at the beginning about the language that everyone has to learn once they get a diagnosis, you made that very clear in a language I think that's very understandable and very helpful to the people who are viewing. I'd like to pass on to Marianne now to do our Q&A session.
Firstly, I'd like to thank both Tim and Dr. Way for your time here this morning. I do feel quite privileged to be sitting here in the virtual room, being able to see you both, and you both sharing such valuable information from a personal perspective for you, Tim, but from such a knowledgeable base from you, Andrew, and certainly a passion I can see that you have in the research and treatment for AML people. So I'm sure the people out there are very grateful for that very comprehensive and, you know, beautiful presentation that you've just given. We do have a lot of pre-submitted questions that people give prior to the AML webinar. And I know going back to our first speaker, Tim, you gave a very sensitive and holistic explanation of how treatment impacted you in your, in your personal world. I'd like to just touch on the first question that was submitted in looking at the management of people from rural and regional areas. I know, Tim, you were you mentioned you were quite proactive in seeking the appropriate treatment team when you were initially diagnosed, and you had to travel 3.5 hours to actually seek the appropriate support that you got. Are you able to share with us, how you went about that a little bit more, how you sought the appropriate treating team, and then following your transplant, how that regional rural support looks like for you? I would imagine it would involve telehealth, but are you able to share with everybody how that support has been?
Well, yeah, just to give a little bit more information about my situation without going into too much detail, I think the issues for me being in a regional centre were obviously the availability of a specialist, the availability of a haematologist. There wasn't one at the time. Mm-hmm. I think there was an issue with the knowledge and awareness of the local medicos. I can't understand why I wasn't referred immediately to a city haematological service or haematology service. When I did sort of press to be referred elsewhere, I came under pressure from some local GPs because I think they were loyal to their own local services. Later on, after treatment, I'd had a little bit of trouble getting support from the local hospital after discharge, because it was sort of like a condition of discharge that I should have access to blood transfusions and that sort of support. So they were issues. And then, of course, you go on to things like the inconveniences and the expense of travel, which, of course, is always a thing. And I talked about the difficulties of being relocated and having to relocate. But I must say, I think the situation in a lot of those areas is improving, and I believe you might be able to say more about this, but I believe the Leukemia Foundation is actually being quite active in the Set the Standard project. Was that sort of aiming at consistent approaches to blood cancers around Australia? Anyway, I think it is, that's my impression, that it's improving. One of the hospitals that I was treated at had an outreach service, which was quite handy because I didn't have to travel as far for my sort of recovery appointments. And of course, the support of IPTAS, the Transport and Accommodation Scheme, was invaluable, as well as the support of the Leukaemia Foundation. So certainly there is a lot of, and of course you mentioned telehealth. That's been amazing. For an appointment, not to have to travel to the capital city and travel back, but just to be able to do it via video call has been fantastic.
Thanks, Tim. From your perspective, Dr. Way, in regard to telehealth and the follow-up of patients with AML, what have been the considerations that you and your team, the haematology team, have needed to make to provide that ongoing support for people following, who are in that rural regional area?
I think prior to COVID, the amount of telehealth that was done was probably only a fraction of what it is now. And I guess one of the silver linings of COVID is that it sort of rapidly brought the whole medical community into a scenario where doing telehealth has now become almost routine. For leukemia, for instance, it's actually very effective because, especially once patients are in remission, most patients will know that the critical thing we need to do is just check that the blood counts are okay. If the blood counts are okay and the patient feels well, then in many cases doing that by a telehealth appointment without having the patient needing to travel has been, I think, really important for quality of life. The other reason we needed to move to telehealth was also because when the hospitals were becoming more frequented by COVID positive patients, we were trying to protect our patients from coming into an environment where they might be exposed to getting COVID, having a very poor immune system because of either the treatment or other health issues. So I think it looks like telehealth will be here to stay, and I think that's a very welcome change. What we really need to do is also make clinical trials deliverable by telehealth, and that's a much slower process, which unfortunately hasn't taken on as quickly as we would like, mainly because the way in which trials are done are still moving much more slowly than what we're doing in the routine clinic. And lastly is the potential to deliver hospital in the home therapy. I know some hospitals have resources to do treatment in the home, but that is definitely not a resource available to all hospitals around the country. And I think if those things were made more accessible to people, then the quality of care in terms of patients being able to stay at home rather than living in the hospital a lot would be transformative. So hopefully those would be future goals: more telehealth where it's appropriate and more home delivery, again, where it's feasible.
It's quite an exciting space to be venturing into, and I know a lot of looking at the many different healthcare professionals that need to be incorporated into this space. It is quite exciting times that we are looking into that. The holistic approach to care, recognizing, especially for those regional rural people who there is that notion of there's no place like home, so that other contributing factor to health and well-being. You mentioned clinical trials, and that is one of the questions that came through that was pre-submitted. In regard to clinical trial options, some people might find clinical trials. How do you feel about, or how is the approach given to those who may come to their treating haematologist having found a clinical trial that they may feel is of benefit to them? How are those conversations handled, and then do they remain under the guidance and care of their allocated clinical haematologist, or do they then come under the care of the clinical trial team?
Often people that do clinical trials are often doctors who also work in routine clinical care as well. So there's no such thing as I think a haematologist who only does clinical trials. And so Hopefully each hospital has some doctors that have an interest in clinical trials and will run those trials and act as, I guess, a guidance to the unit as to what trials are available and what trials patients can be referred to if they're not being done in the centre concerned. There are some resources available. I think there's a Clin Trial Refer website which is used, the Australian Clinical Trials Registry. But the problem is just knowing what trials are out there is difficult because it's hard for a patient to know whether that trial is relevant for them. And so for that, a referral to someone who can provide the correct advice is sometimes not easy to find, but absolutely critical to try and get onto the right treatment. And it's very difficult for patients because they're at a huge information disadvantage, and enormous trust has to be placed into their treating physician, who may have a varying amount of knowledge. They may or may not be an expert in that area, and it's not easy for the patient to know that. And so unfortunately, there is a little bit of disparity according to which hospital someone goes to, which physician they're allocated, and how much information and knowledge and also capacity for referral that particular physician has. And so that is unfortunately the variability and almost the serendipity of which hospital someone goes to initially.
Andrew, can I jump in and ask you, what would you say to the audience around seeking second opinions and seeking that, if you do find that perhaps, or you find a clinical trial that looks like it might be relevant, but really you don't understand the intricacies of it and you need a haematologist to talk you through that, and perhaps your haematologist doesn't have the full knowledge about those particular trials. Like you said, there's some differences between that knowledge and between hospitals. Seeking second opinions can be challenging for patients to bring that up. What do you say? What would you say to the audience around, if they're needing, what to consider and how to go potentially about doing that?
Yeah, it is a very complex process. The first thing is to make your physician aware of your potential willingness to explore clinical trials. And so whatever the physician recommends, if the notion of clinical trials hasn't been brought up, then I think every patient has the right to say to their physician, is this the best treatment? Are there any clinical trials available that could offer me something potentially more effective? And then to listen to that answer. Obviously, some patients are quite savvy and can go onto the internet and do searches to find things which are available, and then they may bring that specific trial to the physician to get their comment. What we sometimes do is we do telehealth consults with the patient's physician and the patient, and so that way the patient can listen to the discussion between I guess a leukemia expert and their own physician. And then that way, it's almost like getting a second opinion, but doing it in collaboration with their physician rather than separately, which I think is very important. I think sometimes it can be counterproductive if a second opinion is sought without the knowledge of the physician, because then people can get two sources of information, which can be very confusing. So I think the first step is letting the physician know that there's a willingness and interest in trials, to asking the physician what trials are available, and then if there are trials available, potentially setting up a discussion with a second person if they're not in the same hospital to discuss whether it's feasible or appropriate.
Great, yeah, great suggestion. Certainly, I think that's a really inclusive and collaborative approach to managing that, what can be a very sensitive and difficult conversation. So yeah, appreciate that.
And quite empowering as well for those who may be in that space where they're, apprehensive about feeling all right about approaching their, life choices in that way. This could be a question for both Tim and Andrew. I'm just wondering one of the pre-submitted questions, what do you see as some of the common long-term recovery challenges that people with AML have?
Please go ahead, Tim.
Well, first of all, there's always that coping with the fear of relapse. And I think that will be with me for all my life. Although all the indications in my case are that I'm okay. I can't say I'm completely fully recovered, but certainly the transplants worked. And I think just being positive in the face of the possibility that you might relapse. I think there are other possible medical issues that arise as a result of the treatment. So in my case, a little bit of GVHD, and there were some other things that happened, as a result of the treatment and recovery that still have ongoing implications. Managing the GVHD in anyone who's had a bone marrow transplant, I think, is a challenge. Just continuing to manage the mechanics of your recovery. So just in the last few days, I've been negotiating. I had to get a new script because my script had was out of date and was rejected by the pharmacy. I've had to negotiate some vaccinations that are done as part of the follow-up to bone marrow transplant, which I happen to miss. I'm having to change appointments around all of those, which is fine, except that's all added to a busy full working life. And now that I'm pretty much back to normal, that's still all ongoing. But I think probably the main thing is just maintaining that balance and perspective. I remember my haematologist saying that he was afraid that some people in the long-term recovery seem to stop being vigilant about their health. And I'm not sure whether that was because they no longer care or they've sort of given up, or whether perhaps they feel like they've recovered and that nothing can touch them. But so I think you do have to maintain that vigilance, especially after a bone marrow transplant, and in your health generally. But by the same token, not get too bedded down or bogged down in fear and negativity, and so just maintaining that balance, and also not getting too complacent, I think, too, as well. Andrew?
I asked him to speak because I knew he would say exactly what I've observed as well, and that is the fear of the leukemia coming back is a really, really sometimes for some patients almost paralyzing fear, and I think it's really important for physicians to try and help our patients understand how to gain confidence from what's going on, again, in a situation which is completely invisible to the patient, also to physicians as much as possible. So the first thing is the development of these new technologies which can measure much lower levels of disease. And I think having something quantitative, very sensitive, so we can say to the patient, look, we can't detect your leukemia down to a level of 1 in 10 million cells, as opposed to 1%, which is only 1 in 100. I think that information is quite reassuring for a patient, especially if we can do it off a blood test rather than the bone marrow, and we can do it relatively frequently in the first year after diagnosis, because that's the highest risk period for relapse. The next thing I do is to try and give patients some understanding of what the risk is of the leukemia coming back. And two numbers which I usually tell patients is that after 3 years of being in remission, the risk of leukemia coming back is about 3%, which I think helps the patient to maybe think, well, maybe this is now looking less likely than what it did in the first 6 months. And then at 5 years, the risk of it coming back is 0.3%. And so those milestones, getting to 3 and 5 years and still being in remission, I think gives the patients a target to go for. And I think that sometimes is helpful to give the patient some idea when they should start to let go of that fear and try and move back into normal life. And the other thing which we try and do is to make the appointments less frequent once we're comfortable that the chance of relapse is lower, because I know a lot of patients have incredible anxiety coming into the clinic office and getting the results of their blood test, because that fear of being told, oh, you've relapsed, is almost always there. So having, in fact, less appointments means that the patient gets less stressed fewer times each year. The last thing, which is really important for the long term, is that we've noticed that some patients have quite impaired exercise capacity, and just this common report of being tired and not being able to do what they were able to do prior to getting the diagnosis. And that's always been a bit of a mystery, because the blood counts look okay. We know the patient's in remission, and yet they just report tiredness and fatigue. We did a study recently where we actually put people onto an exercise bike, and we measured what we call the VO2 max, which is the exercise capacity which high performance sports people measure. And we were quite shocked to see that patients who'd been through chemotherapy had really impaired oxygen delivery capacity, a bit like someone who was 20 years older than what they physiologically were. And I think it's starting to make us appreciate how much just being in hospital and lying in a bed for a month can actually do in terms of making people lose muscle bulk and exercise capacity. And I think what that's telling us is that we need to be much more proactive in developing more sophisticated exercise strategies during the hospital admission and in the post chemotherapy phase, in order to try and prevent that physiological decline. Otherwise, although the patient may be in remission, then it may take years before they become physically capable again to how they were before. And I think that's going to be a new area of research in the future.
What a lovely and sensitive response, to the question around, how we manage AML and living well with AML. And certainly the Leukaemia Foundation, we are piloting an exercise program. So, please go to our website and look into that, because as Dr. Way says, we too believe and promote exercise as a very important, important thing to be embracing post-treatment and transplant. One of the questions that has been popped in the chat is looking at that balance around quality of life and seeing friends when we now live in a COVID impacted society. Are you able to, just help answer how they manage the risks? Because we all know the importance of maintaining connections as human beings, but certainly I know that a lot of patients, and it came up yesterday too for the carers, just looking at, when is it safe? What are the boundaries? What we should put into, what we should put as priorities? How do we manage ourselves? In the day-to-day now that we're living with COVID.
What's been your experiences, Tim?
I think the question, if I saw it correctly on the chat, was about contact with others versus protecting yourself in sort of COVID times. It probably hasn't been so much of an issue for me, because I think one of the things that I've found in the whole process is I've become much more private. I think I've become less outgoing and happy just to stay in my own environment and enjoy things like my garden and the sort of recreational exercise, riding, walking. And I have had a good recovery and haven't been too badly immunocompromised over the time. So I'm probably not the best person to answer it in that regard. But always a challenge, obviously.
I think it's something which physicians and nurses probably need to be more proactive in asking their patients, because I think we often make the mistake that we assume the patient knows what they can and what they can't do that's safe. And I think the reality is that that knowledge is quite variable. So, for instance, I've seen some patients where, 2 years out from the diagnosis, they're still, restricting their diet and not going out and seeing their grandchildren, etc. and that's because they just felt that their immune system was permanently affected by leukemia. So we have to really explore that knowledge and make sure that a patient's insight is aligned with what we think is safe and appropriate for them to do. And on the flip side, you get patients who do the opposite, where they go out and do all sorts of things way before it's probably safe to do so. So I think the bottom line is communication and not assuming anything. One, from the patient side, by asking your doctor or your nurse practitioner or nurse coordinator, and from the physician side, asking the patient and also speaking to the family to make sure that we're aligned in terms of where the patient is. But in general, we definitely try and encourage normal behavior, normal social interactions with family and the wider circle, if the patient wishes to do so, and as soon as it's physically and medically safe to do so.
Absolutely. Connections aren't necessarily only with people in our world. We choose connections with different passions that we have as well, like the garden, for instance, Tim. Where we want to spend time. So I think they're very important messages for all. Just both of you, another question. What would give someone the best chance to remain in remission has been one of the questions submitted prior to today's session.
Obviously, the basic things like maintaining good health, because good health means a good immune system, and a good immune system means the body's got a greater capacity to fight off infections, and also to have the immune system eliminate low levels of residual leukemic cells. From a medical perspective, preventing relapse is our number one research goal at the moment, because getting patients into remission is much more achievable than it was 30 years ago. But keeping people in remission, stopping relapse, is still the number one research goal. So the way we try to do that these days is to understand leukemia in greater detail by doing a lot of mutation sequencing and using that information to decide which patient should have a transplant, as Tim has had, because in that situation, we feel the risk of relapse would generally be 60% or higher. And so to try and reduce that risk, a transplant is often performed. There's also new therapies which will hopefully become available in Australia in the future, which will enable therapy to be given for patients in remission who can't have a transplant because, one, they don't have a donor, or two, not fit enough to have a transplant, which is definitely the case for some patients. So offering new therapies to try and get rid of that, the iceberg beneath the ocean surface, and try and reduce leukemia with therapy which is often tablet-based, not particularly toxic, but able to chip away whilst the patient gets on with their normal life, I think will be a really important future objective. And lastly, to utilise those new technologies to measure the leukemia, and if it is starting to come back, to do something about it many months before the patient becomes unwell. I think those are the different avenues which in the future will hopefully be beneficial.
So in wrapping up, I'd like to invite Tim and Dr. Way, if they could just share like one key message that they would like the audience to take away from today about, living with AML and the treatments and researches. Just one thing that you think is really important that people know. Tim, do you have any thoughts on that?
I do. I attended a Leukemia Foundation support group webinar last year, and one of several. And towards the end, I think people were asked to just make a comment, and I always remember this. One participant said, "Every day is a gift," and I decided to make that my mantra. I think to just be positive as you can. Think of every day as a gift is a great way to approach it.
That's lovely. Thank you. What about you, Dr. Way? What would you like people to take away from today?
I think my main message is that the treatments are evolving very rapidly, but we still have a long way to go. And I know as a physician, we're always amazed at how resilient many patients are, but that's often a stereotype as well, because many patients are not resilient, and we have to learn to understand how to manage patients as individuals. And there's no set way of this is right and this is wrong. And I think our system needs to increase its flexibility to deal with all kinds of different scenarios. Patients who live close by and where management is easily accessible, and like Tim, where they might live really far away. How do we increase the ability for patients in the country in particular to access high quality care more easily, and not because they just happen to be more forceful and cut through the initial barriers as Tim had to do. That shouldn't have to happen, and we need to increase the ability of every patient to access good information and also high quality care in a more equitable manner. I think that's the key challenge. And so I hope that all of the stakeholders involved in managing leukemia will try and work together and make healthcare more equitable, because I think definitely, to me, working in Melbourne and knowing that the level of expertise we can provide in the centre of Melbourne is not the same around the country is the greatest fear I have, because that means that patients aren't going to have the same opportunities to have a good outcome like Tim has had. And so that's what we really need to change.
And I'd like to introduce our next speaker, Professor Paula Marlton. Paula Marlton is the Head of Leukaemia and Deputy Director of Haematology at the Princess Alexandra Hospital and Professor of Clinical Medicine, University of Queensland. She is an MD Anderson Cancer Centre alumnus and has extensive experience in clinical trials and translational research. She established and directs the Cancer Collaborative Biobank, which was formerly known as the National Leukemia and Lymphoma Tissue Bank, has served on the ALLG Executive and was founding chair of the ALLG Laboratory Science Committee. She served on the board of the Leukemia Foundation for Queensland for 13 years and the board of QIMR Berghofer, and continues to serve on several government, college and industry advisory boards. Welcome, Paula.
Thank you very much for that kind introduction. It's a great pleasure to be with you today to share some of my thoughts on acute myeloid leukemia, or AML for short, from a clinician's perspective. And can I add my thanks to the Leukemia Foundation for organising this forum, which I think is a great opportunity for us to learn from each other. I'll try to cover some key areas today. I know Professor Way has talked about the epidemiology of AML, so we'll move straight on to what symptoms might occur if you have AML, how the diagnosis of the disease is made, what are the different subtypes and risk categories of AML that we talk about, how treatment decisions are made, and indeed what the treatment options are currently. Now, we know that the treatment of AML is still suboptimal. However, the survival of our younger AML patients has really significantly improved over the preceding 5 decades. So this is data from the MD Anderson Cancer Centre, whereby you can see that survival outcomes from the 70s was much less than the current survival outcomes depicted here in brown of the current era. And there's been progressive improvements over the decades to this now current survival outcome. But you can see that we still have work to do, and we'd like to continue to move this survival curve upwards. Now, for our older patients with AML, there has also been significant survival improvements, but there is still much more work to be done. It's a much more difficult disease in the older age groups. And fortunately, this has been an area of research focus, and there have indeed been some exciting advances in this group. Now, why do patients get AML? When that diagnosis is made, it's very normal to think, why did I get this? What has caused AML in my body? And in any individual, unfortunately, we really don't usually know. But at a population level, we do know there are certain risk factors for the development of AML. For example, if you've been exposed to a lot of radiation, which we know from atomic bomb disasters and nuclear disasters, there is an increased risk of developing AML. People who work with a lot of benzene are at increased risk. Some people have a strong family history of leukemia, and we know that there is an underlying genetic predisposition in some families for the development of leukemia. Down syndrome, in fact, is a risk factor for the development of leukemia. If you've had another cancer and received chemotherapy or radiation therapy, a small percentage of patients will go on to develop so-called therapy-related AML. If you've had a prior blood disorder, such as myelodysplastic syndrome or myeloproliferative neoplasm, again, small groups of patients may transform from these more indolent conditions to a so-called secondary AML. And we know that increasing age itself is a risk factor for developing AML. Now, we know at the biologic level that AML is caused by errors or damage in the genetic code of the blood-forming stem cells. These are the cells within the bone marrow that are the immature master cell or the parent cell that lead to the development of our mature and functional blood cells, which circulate in our body to provide very important functions. And this occurs through a whole series of maturation steps down either the myeloid development line or the lymphoid development line. And today we're talking about acute myeloid leukemia over on this side. Now, if there is a problem or damage to that genetic code which controls this developmental process, then the functional blood cell development may be blocked. And these cells, these immature, non-functional myeloid blast cells, will accumulate in the bone marrow and eventually may spill out into the peripheral blood, where we see these very abnormal cells that shouldn't be there circulating. And these are known as the leukemia cells or the leukemic blasts. So what do patients experience who have got AML? What are the symptoms that occur? Very often they're quite non-specific, and it may take quite some time before it's understood that AML is the underlying problem. The symptoms result from a consequence of those reduced numbers of functional blood cells. So if the normal white cells, which are infection-fighting cells, are very low, patients may have recurrent or prolonged infections which are difficult to treat. And these are manifest as the features of an infection: temperatures, perhaps a cough if it's chest infections, and so on. If the red blood cells are very low, patients become anemic. And this is manifest as a great deal of lethargy and fatigue, often shortness of breath, and patients will look very pale. This is due to a lack of oxygen to the important organs of our body. If platelets are very low, these are the cells that prevent bleeding, then abnormal bleeding may be the first manifestation of leukemia. And this is often noted first in the skin, where it could just be easy bruising with minimal trauma. Or sometimes it's nosebleeds or gum bleeds, if that's where the low platelet problem occurs. Other patients have symptoms related to the actual physical accumulation of these abnormal blast cells, usually in the form of bone pain from inside the bone marrow, but this can also occur in other places such as the gums, and swollen abnormal gums may be the first sign. So you can see that it's a whole range of different non-specific sorts of symptoms that can occur with this disease. Now, once we're suspicious of acute leukemia from those peripheral blood findings, then we confirm the diagnosis with a bone marrow examination test. And this is where we take a sample of the blood-forming factory from within the bone marrow, which is taken from a large bone in the back of the pelvis here, where the bone comes very close to the surface. And this is done under local anaesthetic and sedation through a simple needle. Now we take that precious bone marrow sample and we really do a loaves and fishes with it in the laboratory, where a whole range of very important tests are conducted. The first of these is, again, looking under the microscope to identify those abnormal leukemic blasts in the bone marrow and a reduction in the normal cells that we would usually see developing in the blood-forming tissues. Some of the sample goes to a special machine called a flow cytometer, where we're able to measure the proteins on the surface of the cell, and that allows us to characterize whether it's a myeloid disease or a lymphoid disease and the specific subtype of those from the surface characteristics. We also conduct special tests known as FISH, where we are able to look inside the cell at the actual chromosomes using colored probes, which identifies abnormalities at the chromosomal level common in leukemia. A more detailed look at the chromosomes inside the cells is a full cytogenetic analysis, where the cells are allowed to divide and actually then harvested at the point of division when we can see all of the chromosomes inside the leukemic cell. And these are then analysed, looking for abnormalities that are characteristic in AML cells. And more recently, over the last decade or so, this process known as mutation profiling has become very well developed and is now routine in our assessment of acute myeloid leukemia. Now, this is whereby individual genes within the DNA that make up these chromosomes are analysed for mutations, and we can test hundreds of genes, and we know those that are commonly mutated in AML and contribute to the development of that disease. And all of this laboratory testing allows us to make the diagnosis, assign a subtype of AML, know something about the risk stratification of that subtype, identify potential drug targets that might be useful in the treatment, and indeed identify laboratory-based disease monitoring strategies that can be used to monitor the disease through the treatment. Now, the subtyping or diagnostic classification of AML is a very complex process, as you can understand from all of those testings. We currently use the WHO classification, where all those laboratory characteristics together lead us to a subtype of leukemia, and there's more than 30 different subtypes. The most important of these are the cytogenetics and the molecular profiling, and this pie chart here just simply serves to illustrate how very complex the field has become. This demonstrates all the different subtypes just based on the molecular analysis, and you can see how many different subtypes there are. And this is already out of date, with this level of knowledge evolving all of the time and our classification skills improving constantly. So AML itself is really just an umbrella term to identify a generic diagnosis from which there are many, many different specific subtypes. Now, how do we utilize all that complex laboratory-based information in clinically useful information? Well, this now refers to the prognostic categories that we use. And this is a method whereby the different genetic or classified subtypes of leukemia are grouped together according to the outcome of patients given treatment for leukemia. And that distills the groups down into those with the most favorable outcomes here in the blue survival curve, and those with an intermediate survival outcome with treatment, and those indeed with an adverse outcome in terms of survival following treatment. So we group those different classified subsets into these three clinically recognizable subsets. And this is a globally accepted method of clinically classifying prognostic groups in AML. So once we've made the diagnosis and we're waiting for all of that very specialized information to come back from the laboratory, we're also thinking immediately about what treatment options might be suitable for this individual patient in front of us. Now, many complex factors need to be considered when making treatment decisions, not the least of which is the actual treatments we have available. Chemotherapy for AML was introduced in the early 70s in this form of a dual agent treatment known as the 7+3 regimen. And this is still in use today. And this transformed a previously universally fatal disease into one where some patients could survive AML. Also in the 70s, bone marrow transplant was developed, and this too improved the outcome and survival of patients with AML. But then look at this timeline. Treatments really stagnated for the next 40 years. There were plenty of clinical trials conducted, but none of these agents improved the outcome compared to our backbone chemotherapy. Azacitidine was introduced, but this really only benefited a small subset of patients, and none of these other clinical trials turned out to allow approvals of new drugs, which was obviously heartbreaking for those of us who were in desperate need of advances in this field for our patients. Fortunately, however, all that has dramatically changed in the last 5 years, where we can see no fewer than 9 new agents have been approved in the United States, where usually the approvals occur first, for the treatment of AML, starting here in 2017 and all the way out to more recent days. And many of these are already available in Australia or going through the regulatory process to make them available here for our patients. So this is very exciting, really heralds a whole new era in the management of AML. So now that we have a few more tools in our toolbox, how do we make the decisions of what to use for individual patients? Well, there are many complex interacting factors that need to be considered, all of those disease factors I mentioned in the diagnostic workup, but also individual patient factors. Some of these are biologics, like the age, of course, very important, other medical problems that patients may have, which we know as comorbidities. And all of these together add up to the relative medical fitness or indeed frailty of the patient. And this is also assisted, this assessment, by the routine tests of organ function of the heart, lungs, kidney, liver, etc., but also increasingly by specialty frailty assessments, which are really more of a functional assessment of how patients are able to function in the community and give us good insight to how they might be able to tolerate sometimes very aggressive therapies for this disease. And of course, there are important personal factors, patients' personal wishes and beliefs. There's psychosocial supports and resources, where they live, what are the logistics of delivering therapies, and of course, individual cultural factors, including language and their own religious beliefs. So it really takes a village to treat an AML patient, and we have huge multidisciplinary teams that come together to support patients through their treatment journey with AML. Not only the medical team, of which haematologists are just one component, such as me, there are other medical specialists that help us along the way with specific complications. And of course, the GPs are essential partners in the care once patients leave the hospital. We have expert nursing teams who provide expert and compassionate care in both the inpatient and outpatient setting. And some of these are specialist leukemia nurses that we're very fortunate in the major centres to have these days, some of whom subspecialise in the delivery of support to particularly younger patients, adolescent and young adult patients. And our nursing teams are very helpful in providing assistance with the complications of treatment, the side effects of treatment, not only the medical team, but also our nursing teams. Pharmacy teams are very important in knowing all of the details of our chemotherapeutic drugs, their interactions and special delivery methods. Psychosocial team of social workers, psychologists, psychiatrists are very important for supporting the mental health of our patients. We have a big team of allied health professionals who all contribute expertise. The palliative care team also contribute multifaceted roles, not just at the end of life for patients, but also often much earlier in the journey, where they can add to the medical nursing and psychosocial care of patients with planning or considerations for end of life, but also for specific symptom control as well. And we're very indebted to our external organisations like the Leukemia Foundation, who provide outstanding support for our patients externally. Now, one of the very first decisions that the big team and the patients together make is whether we will be going down an intensive treatment pathway for our younger, fitter, medically fitter patients, or whether a less intensive treatment will be more appropriate. So for those patients who are deemed medically fit, the goal of therapy is to cure the disease. Clinical trials are always our top priority for treating patients, no different in the medically fit subgroup. The backbone of treatment for this group, though, is chemotherapy, a generic one-size-fits-all, if you like, chemotherapeutic approach, which is still to this day largely based on the 7+3 regimen from the 70s. That's delivered in 1 or 2 cycles with the aim of inducing a remission from the disease, which is then consolidated with further chemotherapy, which is less intense, but still pretty intense, delivered in 2 to 4 cycles. Now, where all the developments have been with our new therapies that I showed you is in this area of targeted therapies for specific subtypes of leukemia, which we add into the chemotherapy backbone. So, for example, if our mutation profile reveals a FLT3 mutation in the leukemic cells, then we are able to add in a specific FLT3 inhibitor in the form of an already approved drug like midostaurin or newer agents which are still in clinical trials. If we see an IDH mutation, we are able to use an IDH inhibitor in conjunction with chemotherapy in the clinical trial setting. For some subtypes of patients, we use a targeted therapy that targets a surface molecule known as CD33, which delivers its targeted treatments straight to the leukemia cells. So these are the exciting additions to that backbone of chemotherapy. Now, once we've achieved a remission, then considerations are given to maintaining that remission for as long as possible. And so for some patients, that may include consideration of an allogeneic stem cell transplant. This is a very highly intensive therapy only for selected patients with a higher risk of relapse who are definitely fit, in remission, and have a stem cell donor. So certainly not available for the majority. Other strategies that are being pursued to maintain that remission from the induction and consolidation therapies are these longer-term, well-tolerated post-remission maintenance therapies that may include some of the targeted therapies that I mentioned, or might be in the form of a more generic type of oral therapy, not yet available in Australia. This is an oral form of azacitidine, but which we know from clinical trials will lead to longer remissions and we hope will become available soon for remission maintenance. And what about our older patients who are less fit and deemed at high risk of toxicity from intensive therapy, who will go down a less intense pathway? For these patients, our goals will be to induce remission and extend the life, but maintain a high quality of life. Again, clinical trials are our top priority, and through the work of clinical trials, and indeed our colleague Professor Andrew Wade was instrumental in the clinical development of this new treatment, venetoclax, which has dramatically changed the treatment landscape for older, less fit patients. It's an oral tablet used in conjunction with an injectable azacitidine, and facilitates that more outpatient-based treatment. It's given in continuous cycles, and although less intense, it certainly still requires monitoring and support of patients. And here from one of the clinical trials, I've shown a survival curve showing in blue that this does indeed improve outcomes for patients. And harking back to an earlier slide where I showed you some real-world statistics from one of the big cancer centers in America, where we know there's a lot of work to be done for our older patients, you can see that although this isn't directly comparable to real-world data from a trial, you can see that we're very optimistic that these survival curves will continue to improve over time as these new introduced therapies take effect. Now, there will be a subset of very old, very frail patients who are not suitable for either of those approaches. And for these patients, the most beneficial approach will be supportive or palliative care. And these are patients who may have many other medical conditions that simply preclude active leukemia therapy. And we can tailor that to the individual circumstance of the patient And that may include transfusions and antibiotic support, symptom management, and our palliative care teams are instrumental here in helping this group of patients. Psychosocial support can be delivered, and this can be done in the home or hospice setting. Now, unfortunately, not all patients who achieve remission may maintain that remission forever, and relapses or disease recurrence may in fact occur. And it's for this reason that we monitor the AML quite closely, at least for the first couple of years, seeking signs of early relapse. And this will involve blood tests and intermittent bone marrow tests. Now, technologies that are being developed, which I know Professor Way has spoken about, to identify the very tiniest amounts of leukemia before a full relapse develops. And we're hoping that there will be interventions that we can give to patients that may avert or prevent that full relapse. We know that the leukemia cells, when they relapse, may in fact change from those that were identified at the beginning. And so different targeted therapies may become appropriate at the time of re-emerging disease. Now, once a relapse has occurred, this is a much more difficult situation to manage. It does require a full repeat laboratory assessment, just like at diagnosis, to assess any of those evolved changes I mentioned. And again, the treatment will depend on many, many factors and may include, again, as a priority, a clinical trial to continue that endeavour to improve outcomes, might include more or indeed less intensive therapy, an allogeneic stem cell transplant, different targeted therapies, or indeed in a very advanced situation, it may be more appropriate and more beneficial for the patient to receive supportive and palliative care. So in conclusion then, AML is always a very serious, life-changing diagnosis that really results in a crisis point in any individual's life. But it's comforting to know that cure is a realistic goal for many of our patients. The care, though, is complex, requires a large multidisciplinary team and multiple resources. It is definitely not an easy journey, and indeed probably one of the most complex treatment pathways of all diseases. Treatments are definitely improving all the time, and I hope I've illustrated that for you today. And that's through the enormous research activities that are ongoing and that we are all supporting. So I feel as though we are on the brink of a new era in AML therapy. Excitement and optimism is very high. And just to mention one such therapy that may emerge in the future, that is around CAR T cells. These have been very successful in the lymphoid leukemias, where you will have heard of CAR T cell therapies, but there are very many more challenges in the myeloid diseases where we don't have a uniform and straightforward target like there is in the lymphoid leukemias. The diversity and heterogeneity of myeloid disease makes it much more difficult to develop a CAR T approach. Nonetheless, it is being worked on. There are very early clinical trials, and we are certainly hopeful that CAR T constructs will be one of those things that improves the outcome for patients in future generations. Thank you very much for your attention, and I'd certainly be glad to address any questions through the Leukemia Foundation.
Thank you so much for that, Paula. I think, as we know, when somebody is diagnosed with AML, it's a very difficult time with a lot of overwhelming information. And I think you spoke very clearly in a very thorough way of explaining parts of what people might have missed or haven't had the courage to re-ask of their doctors since being diagnosed. So really appreciate that. So this draws the webinar to a close, and I'd like to take the opportunity to thank, firstly, the supporters of the Leukemia Foundation. Without them, we wouldn't be able to deliver education events such as this. Obviously, I'd like to thank again Tim for giving us your story of how life has been for you, and really appreciate Dr. Andrew Way coming through and talking a little bit clinically to start with to ease us into the research side of things. We really thank you for sharing your knowledge and expertise and participating in this. And lastly, and most importantly, those of you who are living with AML who have joined us today, we encourage you to take the information you have heard to further the conversations with your healthcare teams, family, friends, to help you guide in your healthcare decision making. Thank you for joining us today, and goodbye for now.